I realized long ago that even in such a mechanistic discipline as surgery, the proper relationship between the surgeon and the patient is as important as surgical skill. I once worked with a surgeon who had acquired a high level of skill in the mechanics of surgery. At that time, the most demanding surgical procedure done was thoracolumbar sympathectomy for hypertension. This entailed the complete removal of the sympathetic portion of the autonomic nervous system, a continuous chain of nerve fibers and ganglia running from the upper portion of the neck through the chest and abdomen and deep into the pelvis. This surgeon was able to remove this entire anatomical structure in one piece through one small incision along the lower ribs and in an average time of 30 minutes. Our operating room was often crowded with medical students and junior residents who came simply to see this wizard operate. His skill at other surgical procedures was equally impressive. However, regardless of the surgical procedure, that his patients had more postoperative complications and deaths than patients operated on by any other surgeon at the hospital. There was another surgeon on the staff who had almost the same technical competency. He was able to do the same procedures, but he took a little longer, and he lacked the panache of the hero surgeon. His postoperative complications were half those of the other surgeon. The only difference I could see between the two men was their relationship to their parents. The master technician never spoke to his patients. He grunted at them for all of 60 seconds on the day prior to surgery, and he left it to the residents to answer patients' questions and calm their fears. The other surgeon spent as long as necessary to explain in detail what he was going to do and to answer patients' questions, leaving them with a feeling of confidence in their surgeon. The term placebo may thus be expanded from the textbook definition of an active or ineffective chemical agent, such as sugar pill, and applied to the state of the patient's mind. Taking this one step further, I believe that under the circumstance of such profound belief produced by any technique, the conscious mind of the patient is able to access the DC system of the body and produce healing. This makes it possible to rationally explain the useful clinical effects of many diverse techniques classified under energy medicine. New drugs are tested in double-blind manner so that neither the dispensing doctor nor the patient knows whether what is being dispensed is an effective medication or placebo. The basic assumption underlying this idea is that the only valid treatment is one that has been clearly demonstrated to influence the target chemical system without the intrusion of psychological effects. On the face of it, this seems like a very responsible and logical way to go about the business of medicine. Certainly, we don't want to have a lot of worthless drugs on the market. However, we are missing the mark in this case. The whole aim and justification of medicine is to produce a relief of symptoms or to effect the cure of a disease. Standing in the shadows beyond the light of present day science is the placebo effect, which is capable of producing the desired medical effect in 60% of clinical cases overall. If the placebo effect could be patented and bottled, it would make millions of dollars for the pharmaceutical company that owned it. Perhaps the most disastrous result of the concerted attack on the placebo effect is the accompanying concept that before any treatment can be legally used on human patients, its mechanism of action must be known. Again, this appears at first to be a laudable idea. After all, we don't want to be treated with any medication or technique without knowing how it works. The problem with this idea is that the way it works must be in accord with present day chemical mechanistic model. Any technique, no matter how clinically effective in relieving symptoms or producing a cure, must be seen to work chemically or must not be used at all. This concept, rooted in the tenets of scientific medicine of the 1930s, was what functionally threw the placebo effect out the window. Because there was no explanation for the placebo effect, according to the science of the day, the effect simply did not exist. Things have changed. The new scientific revolution has provided medicine with evidence for the reality of the placebo effect. All of the techniques listed in the beginning of this section will work. provided that the patient has a profound relief in the treatment's efficacy. In this way, the immune system is activated, the DC control system is accessed, and tissue healing is accomplished. The minimal techniques of energy medicine are quite different. The placebo effect is depicted and condemned by orthodox medicine. In that depiction, an unscrupulous physician deceives a work patient by prescribing a medication and stating that it will work, while knowing that it is actually ineffective. The entire success of this type of placebo effect rests upon the physician as a figure of total authority, with the patient surrendering his or her will to the doctor. Such patients may passively develop a profound belief in the efficacy of the medication, and some may experience a cure. However, these patients are never directly involved in their treatment in any way. In addition, the orthodox physician often unconsciously uses a negative placebo effect to the detriment of the patient. It is now considered to be good practice to tell all patients the truth and to tell those with cancer that it is considered impossible to treat, that they have the disease, and that nothing can be done. They are not told that occasionally similar cases have experienced spontaneous regressions of the cancer, or that there are alternative therapies that occasionally seem to work. In this way, all hope is taken away, and the patient is left defenseless against the disease. Invariably, patients want to know how much longer they may expect to live. Instead of saying that it really isn't possible to guess because of each patient is different, the doctor often gives a specific time frame, such as 6 months. I have personally known of far too many patients who have died exactly on the day that the physician's estimate predicted. The authoritarian statement from the doctor produced a mindset in the patient that not only brought about this physiologically and statistically unlikely event, but also destroyed the patient's enjoyment of the time remaining. Ethical practitioners of minimal energy techniques do not deceive their patients in this fashion. Instead, they tell patients from the start that they are going to cure themselves by learning techniques that will give them control over their own bodies. These practitioners are far more like teachers than healers, guiding their patients into deeper self knowledge and ability. This type of therapy must bring into play much more of the body's inherent control systems than the simple authoritarian placebo. And from the point of view, it must be a more efficient technique. The patients are in control of their own destinies. They make their own decisions and regulate their own healing without being dependent on authority figure. This may be a significant point in the success of these techniques, because developing this sense of independence, a feeling of control and self-determination, has shown to significantly reduce the stress of a serious or life-threatening illness. Several very well done experimental studies have clearly illustrated and substantiated this point. In 1979, Doctors L.S. Schuyler and H. Niesman set up 2 cages of rats that had been inoculated with a malignant tumor. Both cages were set up so that a lengthy electrical shock was given via a grid on the floor at random intervals, delivering a foot shock as a stressor. One cage had a switch that the rats could use to shut off the shocks, a so-called escape routine. Although both cages received exactly the same number and extent of shocks, the rats in the first cage were able to limit the length of the time the shock was delivered, while those in the second cage had to passively accept the same amount of shock. So one could reasonably say that the rats in the cage with the escape switch had a measure of control over his undesirable event. The rats in the second cage, which had no such control, demonstrated a significantly higher incidence of clinical cancers, significantly higher mortality rate, and a swifter course of death. Study was repeated by Dr. M.A. Vicentainer and his colleagues at the University of Pennsylvania in 1982, except that in this case, the type of cancer used was one that rats could reject with their own immune systems. It was found that the rats with escapable shock had a significantly higher incidence of cancer rejections than the rats with the same but inescapable shock. These studies clearly indicate that in any stressful circumstance, any measure of control lessens the extent of stress and results in a significant improvement in resistance factors and healthy outcome. This teaches us several extremely important lessons. First, stress enhances and accelerates cancer growth. Second, providing patients with the maximum possible level of control over their treatment markedly reduces the stress of serious illness and improves the clinical outcome. We are rediscovering what Hippocrates discovered so long ago. To a large extent, the psychological response to a specific disease determines its clinical outcome. I'm reminded of two cases that came to my attention more than a decade ago. Two men, both about the same age, both married and fathers of children, developed leukemia practically simultaneously. One of the men passively accepted this condition, putting his fate completely in the hands of his physicians. He endured massive chemotherapy without complaint, maintaining the attitude that the doctors knew best. The other patient completely rejected the entire situation, refused chemotherapy, and threw dishes and glassware against the wall at home. Both patients had sought from help from the same physicians who prevailed on the first patient to counsel the second to accept chemotherapy. But his efforts were of no avail. The first patient responded poorly to the chemotherapy and was finally given experimental drugs which didn't help. He died within 2 years of the onset of the cancer. The second patient is alive and well today. New light on visualization. Visualization is a technique in which patient is instructed to look inward into his or her body to visualize the disease that is there and to visualize the body's defense system attacking the disease tissues. The technique is used most frequently in cases of cancer in which fairly accurate localization of the diseased tissues can be made through X-rays or other imaging techniques. The patient is given the maximum information about the illness and receives complete access to the laboratory data, such as X-rays, as an aid in forming a mental image of this lesion. The step certainly demystifies the disease and makes the patient part of the curative process, providing him or her with the feeling of being in control. But this cannot be all there is to it. There are enough documented cases indicating that some patients, particularly children, can successfully form an accurate picture of the lesion itself. An excellent example is the story of a patient named Garrett Porter, as told by Patricia Norris in her book, I Choose Life. At the age of 9, Garrett was diagnosed as having astrocytoma, an inoperable and fatal brain cancer. He was treated with X-rays and he began learning biofeedback techniques almost simultaneously. After he had quickly mastered control of his automatic nervous system, Garrett began visualization therapy with Dr. Norris. Not only did he do well clinically, but he was also able to visualize the tumor in detail. One evening, slightly more than a year after he had begun therapy, he called his father and told him that he couldn't find the tumor anymore. In its place, he saw a small white spot. No one except Garrett believed this for fear of the effect that bad news might have on the boy. A CAT scan was put off for a month. But when he was finally done, it was clear the tumor was indeed gone. In its place was a small calcium deposit, the white spot Garrett had seen. In some way, Garrett was able to actually see in his mind's eye an accurate representation of the interior of his body. While he obviously believed in his treatment, such belief was acquired only to gain access to his internal control systems. Once this connection was established, things happened that we cannot now explain. Simple belief would appear to be insufficient to explain the reality of his visualization. Incidentally, Garrett Porter is alive today and in mid-teens. With the exception of some neurological defects caused by the X-ray therapy, he is fine. Science today explains the visual system in simplistic terms that are quite inaccurate. Photons of light are focused on the retina where they form an image of the external world. The pattern of this image is transferred to impulses in optic nerves, and it is ultimately expressed as a similar pattern on the optic cortex at the back of the brain. This process is much like the process a computer uses to form a graphic image on the screen. This graphic image is expressed as a specific collection of individual dots. The more dots there are and closer together they are, the more realistic the image will be. We call this image digitizing. If things were this simple, we should be able to electrically stimulate the optic cortex with a pattern of electrodes arranged, for example, in the shape of a letter A, and the subject would report seeing the visual image of the letter A. The fact of the matter is that even the letter A cannot be perceived in this way. The patient merely reports the sensation of light. We expect that somewhere in the brain such a patterning is expressed on the computer screen of the mind, for example. But we have not found the screen. This may be because it exists only in the state of consciousness, not in the physical brain. I know one of the experimental circumstances in which simple images can be impressed on the conscious mind without going through the visual system at all. This technique was discovered by Elizabeth Roscher, a physicist, and William Van Bys, an engineer. It uses magnetic fields generated by two coils of wire, each pulsing at a slightly different frequency and directed so as to intersect at the head of the subject. When two beams of electromagnetic energy with different frequencies intersect at some point in space, a third frequency is formed. This frequency is the difference between the two original frequencies and is called either the difference or the beat frequency. For example, if one beam had a frequency of 100 kilohertz and the other a frequency of 99.99 kilohertz, the difference would be 0.01 kilohertz or 10 hertz. This is a useful technique for producing extremely low frequencies within a small volume located a distance away from the original transmitters. In Van Bys and Roscher's experiment, the different frequencies were always in the ELF range. The size of the volume in which this occurs depends upon the diameter of the two beams. This technique will be discussed further in a later chapter. Van Bys and Roscher blindfolded subjects saw such simple figures as circles, ellipses, or triangles, which could be changed by altering the frequency of one of the coils. The coils were several feet from the subject's head. The magnetic field strength from the coils was so small that no electrical currents could have been generated in the brain, and the control electronics were located in another room. This technique seems to bypass the entire visual system as we know it, acting directly at the interface between the organic brain and the conscious perception of visual images. If this supposition is even partially correct, it is highly unlikely that the conscious perception level is based upon a digital or nerve impulse system. The technique could not possibly have stimulated nerve impulses in or any part of the brain because the field strengths were far too low and the L frequency cannot produce such stimulation. It is probable that this sensitivity to such low strength, low frequency magnetic fields requires the presence of semiconducting DC elements. If Garrett Porter was accessing his internal DC control system, he also gained access to his total body morphogenic field visually represented within this internal DC control system. And was he in this way able to accurately see the tumor itself? Only time and much more research will tell. Unraveling the healer phenomenon. Before we discuss the other classifications of energy medicine techniques, we need to discuss one that cannot at this time be assigned to any of our arbitrary groups of energy medicine. The healer phenomenon is probably the oldest medical technique, with the origin in preliterate hunter-gathering societies. Yet today it remains the least understood and the most controversial of all techniques of energy medicine. If the healer phenomenon is real, we do not know whether it operates via the placebo effect or whether any energy flow is involved, either from the healer to the patient or vice versa. Part of the problem lies in the deeply ingrained rejection of the entire concept by both scientific medicine and the physical and biological sciences. Nothing will produce more of an uproar at a medical meeting than asking, what about the healer phenomenon? If the healer actually evokes the placebo effect, we should be able to find evidence for this in the common practices of well-known healers. The placebo effect can be activated only by two distinctly different techniques. The teacher used by the practitioners of minimalist techniques of energy medicine and the authoritarian practiced by physicians using known ineffective drugs. In my contacts with healers over the past 20 years, I have found that the genuine ones adopt a business-like attitude towards their practice. Each patient is treated, not taught. No true healers present themselves as authoritarian figures or as persons possessed of mystical powers. If the placebo effect is operating, it must be on the basis of preconditioned patients, not on any actions of the healer. While there are undoubtedly some such preconditioned patients, I have found them to be in the minority. Finally, Chinese healers also work quite successful with animals where there can be no placebo effect. Yet healing works. I have seen remarkable results obtained in a number of life-threatening circumstances. Most authentic healers actually do not know what they do. They know only that they have the gift of healing. They do not question how it is accomplished. Most healers are ordinary people who hold regular jobs and who do their healing treatments in their spare time. The late Olga Worrall, Worrall, was one such person. Auntie Olga viewed her gift in a matter-of-fact fashion. In her later years, she conducted one healing session a week in the basement of a neighborhood church. Each patient was given the necessary time, which was generally less than 10 minutes. Olga presented the appearance of nothing more than a kindly grandmother, an ordinary person, yet her patients reported experiencing a feeling of great calm and contentment and a sensation of having received something. Olga told me that the healing seemed to take something out of her. As she grew older, she had to limit her treatments because of her increasing fatigue. Something other than the simple placebo effect seemed to be occurring. Since we know that the body uses electrical control systems to regulate many basic functions, and that the flow of these electrical currents produces externally measurable magnetic fields, it does not require a great leap of faith to postulate that the healer's gift is an ability to use his or her own electrical control systems to produce external electromagnetic energy fields that interact with those of the patient. The interaction could be one that restores balance in the internal forces or that reinforces the electrical system so that the body returns toward a normal condition. In the past, we had only anecdotal evidence to support the concept. One experiment involved the healer placing his hands on the outside of his cloud chamber, a device originally used to detect the passage of high energy atomic and subatomic particles. Strange things were said to occur within the chamber, but they were poorly characterized. This was further confused by a latter experiment in which the healer, located many miles away, simply thought of a cloud chamber, and the strange events were said to recur. This experiment, while interesting and worthy of duplication, it was uncontrolled and the results have done little to clarify the issues. Unfortunately, the intellectual bias against the phenomenon of the healer is so great that it has been extremely difficult, if not impossible, to get reputable scientists with the necessary equipment to become involved in valid studies. This condition is now changing. The healer phenomenon has become accepted by much of the public, and some forward looking physicians are beginning to think that this technique, as well as other techniques of energy medicine, should be scientifically studied. At the most appropriate time, a young healer named Mitek Werkus has come to the United States from Poland, where the situation for healers is much different. There, the healer is accepted as a valid medical therapist and is subject to licensing by the government. In order to be approved and licensed, a healer must demonstrate to a council of physicians that his or her treatments have actually worked on a specific number of patients. Workus and his wife arrived in the United States about 2 years ago. Workus is convinced that his treatment involves the flow of energy from him to the patient, and that the energy involved is electromagnetic. This is particularly important because he, in contrast to Olga Warol, does not touch the patient. Therefore, any energy involved must be a type of transmissible across space. Of the forces available, only electromagnetism qualifies. I first met the Workuses early in 1988 and had the opportunity to ask MyTech a number of questions that I considered important from the energy transfer point of view. In particular, I felt that if his ability involved a major level of control over his internal electrical control systems, then in addition to being able to project a external field, he should also be able to sense the disturbed electrical fields within the patients at the site of disease. In that sense, he should be able to make a diagnosis not of a specific disease, but of the site of disease. In making this prediction, I drew on both theoretical science and my own experiences as a practicing physician and surgeon for many years. I have become convinced that some of us make a final diagnosis based not only on physical examination and laboratory tests, but also on a gut feeling or intuition of some sort. It takes time to do this, time to talk with the patient in addition to conducting the physical examination. The best example I can think of to show this in action involves the differential diagnosis between acute appendicitis and acute mesenteric adenitis. These two conditions have practically identical laboratory findings and physical signs on examination, yet the former must be treated surgically, while the latter will resolve itself without surgery. The modern physician will more often than not opt for the diagnosis of mesenteric adenitis and not operate, so that the stigma of doing any appendectomy when there is no appendicitis may be avoided. Of course, if the patient really has acute appendicitis, the appendix will rupture and it can be treated sometimes with surgery and antibiotics. In contrast, I have seen older surgeons go into a patient's room, spend an hour, and emerge with a diagnosis. They were right far more than they were wrong. I would suggest that the best surgeons thus make their own diagnosis by some intuitive method that we do not yet understand. When I spoke with Workus, he assured me that he could easily determine the presence of a disease and determine where it was located in each patient. In fact, even when he is first provided with a definite diagnosis in treating any patient, he first scans the total body, holding his hands a few centimeters away from the body's surface, looking for other pathology. He was not sure exactly how he did this, but he felt that he sensed energy coming from the area of disease. He was also certain that when he treated a patient, some energy passed from him to the patient. He also told me that it took much more energy from him to treat cancer or schizophrenia than to treat arthritis, skin conditions, insomnia, or neurosis.